for the opportunity to try to answer this question. So, retinal fibrosis after thrombosis, what does it teach us? This is the kind of title that when the organizer asks you to present on this, you want to probably commit suicide. And this is the reason why the answer is very difficult. So what we felt was like, let's see if artificial intelligence can help us answer this question and save us some time. These are our disclosures. So Giuseppe, can we ask ChatGPT to try answering that question, please?
Absolutely. Here it goes.
So can you provide me scientific literature about retinal fibrosis development after retinal vein occlusion? I've encountered some challenges in accessing detailed scientific literature specifically about retinal fibrosis. The articles available in the public domain primarily discuss the general aspects of RVO, including its classification, risk factors, pathogenesis, and the roles of cytokines and chemokines. Not very helpful. So, Giuseppe, can we go back to our old-style literature review on PubMed? Maybe that's going to help us better.
Good old style. And this is the search that we've done. Retinal fibrosis and retinal vein occlusion. As you can see, it wasn't really helpful, just 3 results.
Are you kidding? 3 results?
3 results.
The whole literature?
Not much, and if we look at these 3 results, they're not very up to date.
1976. I asked you to do a thorough assessment of the literature. That's what you could come up with?
This is all we could come up with, yeah.
Okay. So, as you see, thanks for giving us the most difficult topic. But also because no one knows, so we can say anything. So, Giuseppe, the floor to you.
Thank you.
Let's see if a clinical case can help us understand a little bit more.
So, yes, let's see if we can tackle this topic with a clinical case. And our clinical case starts in December 2022 with a man called Mr. D. And he's 61 years old, and he shows up at our door with a referral from a colleague and friend of ours, which is called Dr. Simona. Thank you, Pippo. This patient, his systemic medical history is very simple. He has a type 2 diabetes since 5 years, and he's in treatment with just metformin. And he also has a Retinal syndrome without any particular disease associated. People sent the patient to us because he noticed a pre-retinal fibrosis in an established case of branch retinal vein occlusion. But before delving into that, we make a step back and we go 2 years back in time to October 2020 and to understand his ophthalmological history. So this is the time of diagnosis. People saw a cystoid macular edema, which was responsible for a drop in visual acuity to 0.2. As you can see, this was the fundus examination and the cystoid macular edema. So later, a treatment strategy was adopted with intravitreal treatments with anti-VEGF, Lucentis and Eylea on a PRN protocol, and it worked very well. In fact, the visual acuity got back to 0.6 and the cystoid macular edema resolved. Important to say that no signs of neovascularizations were noted in this 2 years follow-up time. If we look at the fundus once again, we see, and the OCT of our patient, we see that the cystoid macular edema has resolved. But we can also see that retinal ischemia is coming. So if you look at the superotemporal arcade, there are some ghost vessels and there are signs of internal retinal layers atrophy at the OCT. I want to draw your attention to this particular visit, December 2022, again 2 years from the diagnosis. 6 months pause from anti-VEGF intravitreal treatments, and people notices this retinal fibrosis and a worsening of the macular edema. This is what led to the referral to our clinic, And this is the examination. So the visual acuity was 0.3, so dropped again due to these new features. Anterior segment, unremarkable, and let's take a look at the fundus. In particular, we're interested into the right eye. Again, ghost vessels, some retinal hemorrhages, and we can see that around the optic nerve there's the appearance of pre-retinal fibrosis, which then goes along also in the superior macula. And we wanted to know a little bit more, so we performed a fluorescein angiography, which showed a wide area of retinal ischemia, which occupies most of the supratemporal quadrant and part of the posterior macula. If we look at the details, we see telangiectasia, capillary leakage, shunt vessels, typical features for this pathology. And if we look instead at the late phase of this fluorescein angiography, we can see that there is late leakage, especially in those 2 points, which was associated with neovascularizations as confirmed by the OCT angiography. So we can see those 2 bumps of tissue, which perforates the internal limiting membrane, and they have this yellow discoloration, meaning that they are actively, there's active blood flow, so they're active neovascularization. Here there's another one in the inferior macula. And as it often happens with these patients, the neovascularizations formed at the border between perfused and non-perfused retina. Let's take a look at the OCT. Here we see what people noticed and the reason why he sent it for a second opinion. There's a pre-retinal fibrosis on the superior macula and around the disc, which exerts a slight traction on the retina and worsens the cystoid macular edema. So, Gabriel, what do you think we should do now?
I think we could probably ask the audience. So I know the second opinion was asked to us, but we're being a little bit cheeky. So what would you do in this case? Not all.
Happens.
2-year history of branch retinal vein occlusion with cystoid macular edema. Did very well with injections. Then after 6 months post, this is the situation. Fibrosis, a lot of ischemia.
What about visual acuity?
Visual acuity dropped from 0.6 to 0.2. And if we look at the macular scans, this is the situation.
So you have already an ischemic damage to the fovea, an entire fovea. You have no
Yeah, half of it. But
circulation at that level. So functionally, whatever you do in these patients, I think that the functional results will be near zero. So you can do your surgery, you can discuss with the patient the possibility to make surgery, but he must be very well informed that functionally this will not change the situation. The only thing that you can imagine you will be able to obtain is that you can stabilize the situation by surgery without any functional improvement. That's I think what I would do.
thanks a lot. Now, as the patient previously was able to see 0.6, we were like, maybe there is something we can save. So the recommendation was, how about laser and anti-VEGF? Let's see if we can get something back. But of course, surgery was also on our mind. Giuseppe.
And also, we would like to stress the point that we wondered if faricimab could be of additional benefit in this case, because we've seen in the previous interesting talks that Ang2 has an active role in fibrogenesis, and this patient is showing an initial pre-retinal fibrosis. So, since he had a history of mild diabetic macular edema in this eye, we tried to suggest therapy with faricimab.
What about the risk for worsening of fibrosis?
That's a very interesting point.
No spoilers.
And we'll get to that.
Okay.
But maybe I missed something because I was playing with Professor Bandello and the white light. But if I have put everything correct in terms of time points, and that's the latest fluorescein angiography, it's very clear, maybe you have already underlined that this patient moved to a proliferative status. And therefore, yes, the patient has fibrosis, but that's not the major concern now. Now the major concern is ischemia and neovascularization. So this patient definitely needs laser. Why not? Still there, effective. And this patient also may need some anti-VEGF injections because you want to stop the neovascularization process and the ischemic process. And thereafter, at the end of this, whenever the neovascularization regress, you may consider in terms of, and you have to evaluate whether there might be any benefit, functional benefit or not. After that, you may consider surgery. The role of faricimab in terms of preventing fibrosis, that's a different story. We have seen some numbers saying that in patients treated with faricimab, the rate of epiretinal membranes in diabetic macular edema is less as compared to those treated with aflibercept 2 milligram. Okay, we are talking about different fibrosis, which is subretinal fibrosis, not epiretinal fibrosis. So it's a long story, and obviously we want to see something which is also against fibrosis and atrophy, which are unfortunately a big part of age-related macular degeneration and sometimes of diabetic macular edema.
Indeed.
Yeah.
We totally agree. That's what we felt. Laser and anti-VEGF, and the most potent drug on the market, the newest one, would it give us any additional benefit? So we send the patient back to Pippo, and 6 months later, what goes on?
Something happens. We receive a phone call from Pippo again. And this phone call leads to a second referral because something really unexpected happened. It was July 2023, 6 months later, 4 faricimab injections later, increased preretinal fibrosis and vitreomacular retraction. Visual acuity dropped down even more.
So now vision is even worse.
OCT representation of the case. As you can see, the preretinal fibrosis has increased very much. Before, 6 months earlier, was only located on the upper area of the macula. Now it exerts a traction on the whole posterior pole, and the thickness of the retina has increased very much. We're not talking about cystoid macular edema anymore. This is a thick retinoschisis. And so before we tackle the problem and say pathophysiologically what we think happened in our case, let's talk a little bit about branch retinal vein occlusion. As we all know, retinal vein occlusions, its pathophysiology consists of 2 main areas, pathways. The first is a decrease in venous drainage, which leads to ischemia and hypoxia, and the secretion of proangiogenic factors, which lead then to neovascularizations. We can go for that. I just wanted to add that an increase instead in venous pressure leads to capillary leakage, and inflammations would also contribute to the development of neovascularization. Let's quickly see the therapeutic options. We have 2 main problems in retinal vein occlusions: cystoid macular edema, which is tackled by anti-VEGF, and also steroid injections. As we've seen, inflammation is also a key player here, and retinal ischemia. Standard of care for neovascularizations caused by retinal ischemia is argon laser PRP, in our case sector PRP. We're talking about branch retinal vein occlusions. And
you say PRP?
Yeah, it's not PRP, it's just a sector argon laser, sorry. And current international guidelines suggest that we perform prophylactic laser in the ischemic areas, prophylactic meaning within 90 days of diagnosis, and this could help prevent development of neovascularization. So let's get to the pathophysiology. What we think has happened in our case is the anti-VEGF Crunch Syndrome. And crunch is not a chocolate snack, as one may think, but it is a recognized complication associated with anti-VEGF injections in ischemic retinal conditions. It is mostly associated to diabetic proliferative retinopathy, but also reported in other diseases which entail neovascularizations. It consists of a rapid progression of retinal fibrosis after anti-VEGF injections. And as we've said, in eyes suffering from ischemia and neovascularizations. The time is very quick. Its main time of development has been described as 13 days, with a range goes from 3 to 31 days. Clinical features are vitreous hemorrhage, which may happen from bleeding of these neovascularizations, regression of neovascular tissue, fibrovascular proliferation, and end-stage tractional retinal detachment. Most of all of these patients have a poor visual prognosis, which is usually 0.1 or less. Let's talk a little bit about the molecules which are involved in this process. The angiofibrotic switch hypothesis, we've already heard about this in the previous talk. CTGF and VEGF are highly expressed in proliferative diabetic retinopathy, and we're all familiar with VEGF, but maybe some of us don't know what CTGF is. It is a connective tissue growth factor. It's a factor which induces fibrogenesis. This theory tells that when they're both highly expressed, the equilibrium goes toward angiogenesis, but when there's an imbalance between the two and we decrease the level of VEGF, CTGF is predominant and we have a switch toward fibrogenesis. This is what happens when we make a anti-VEGF injections in these patients. Let's go back to our case. These are the three topical moments. December 2022, first detection of preretinal fibrosis. June 2023, worsening due to crunch effect, which was noted, and this is the consultation that we performed yesterday as a follow-up. As we can see, the fibrosis has increased a little bit more. These are the OCTs, and as you can see, the OCT of November 2023, which was yesterday, shows a complication, which is an initial tractional retinal detachment. This is the only thing that we can do for this patient is to schedule.
Prof. Bandello, you were better than AI in predicting the future in this case. Suggesting surgery would be helpful at some point.
Question of age.
Let's put it into a timeline to make a little bit of order. Diagnosis, treatment for 2 years, and everything goes fine. Then anti-VEGF are stopped. Preretinal fibrosis occurs. Anti-VEGF are then reintroduced because of neovascularizations, and the crunch effect is noted. After a few months, this fibrosis progressed and led to an even higher vitreomacular retraction with this development of this detachment. What do we bring home from this presentation? First of all, is that fibrosis post-thrombosis is a final outcome of an ischemia-driven process. Ischemia is definitely the inciting event, and we can tackle it timely by doing a prophylactic argon laser on the ischemic areas of the retina, which may help preventing or delaying development of neovascularizations. Last but not least, we know anti-VEGF are a very useful therapeutic option, but we have to acknowledge that they can also worsen preretinal fibrosis and vitreomacular retraction.
Thank you.
Thank you very much.
Bravo.
This opens was the way to another big question, especially in Europe, the use of anti-VEGF for treating patients with diabetic retinopathy without macular edema, which is something which is relatively routinely done in the US. It's not likely enough done in Europe, but this is a great question because we have an efficacious therapy when needed, which is laser photocoagulation. Besides that, we know that anti-VEGF do not cause any regression of ischemia, according to the Europeans versus the Americans. But still, some people, especially in the US, use this anti-VEGF for treating diabetic retinopathy without edema or neovascularization.
Totally agree. The only situation where I'm very inclined to put an anti-VEGF in the eye is if there's rubeosis. In that case, it buys me some time. I will do the PRP in 1 to 2 weeks anyway, but the regression at the iris level is very fast. So that's the only scenario.
I do agree, and by extending this further, those may be the cases of florid diabetic retinopathy in which laser is not enough, and you need something more potent and immediate, like anti-VEGF. So coupling laser plus anti-VEGF might be helpful in those very severe cases.